If you've ever felt that sharp, stabbing pain in your heel with your very first step in the morning, you know exactly how miserable it can be. So today, we're going to cut through all the noise and look at what the best scientific evidence actually says about how to treat it, all based on the latest clinical guidelines. It's the classic sign, isn't it? You swing your legs out of bed, you go to plant your foot on the floor, and bam, ouch. That first step can be absolutely brutal. It's a question thousands and thousands of people are asking every single day. And a lot of the time, the answer is hiding right in this thick band of tissue called the plantar fascia. The easiest way to think about it is like your foot's own built-in shock absorber. It's this crucial bowstring that runs from your heel to your toes, supporting your arch. Now, if this is you, trust me, you are not alone. Not even close. Get this, clinical guidelines show that this one condition, plantar fasciitis, is responsible for about 15% of all adult foot complaints. It is incredibly common. That first step pain is more than just an annoyance. It is the single biggest clue we have. It's that feeling that finally makes people say, okay, I need to get this checked out, and it points us directly to what's really going on under the surface. So let's put an official name to that feeling. What is plantar fasciitis really? It's a little more specific than just heel pain. At its core, it's all about that very specific pain right under your heel, which, you guessed it, feels the worst right after you've been resting for a while. When that shock-absorbing plantar fascia gets overloaded, stressed out, and irritated, it lets you know loud and clear with that very first painful step. The good news is, you usually don't need a bunch of fancy, expensive imaging to figure this out. A diagnosis is typically based on these classic signs: pain in that one specific spot, and often limited ankle flexibility. Your doctor or therapist will also probably do something called the windlass test. That's where they gently pull your big toe back to put a little stretch on the fascia. If that reproduces the pain, it's a pretty strong confirmation. Okay, now for the part you've been waiting for. What actually works? This isn't about what your neighbor tried or what you read on some random internet forum. This is the real deal, the evidence-based treatment guide, focusing only on the stuff with the strongest scientific support. These right here are the grade A heavy hitters, the treatments with the best science behind them. We're talking about manual therapy. That's hands-on techniques a therapist uses to get your joints and tissues moving better, along with specific stretching routines, taping for some quick short-term relief, and night splints to keep that fascia gently stretched while you sleep. These are the proven cornerstones of getting better. So let's talk about insoles or orthotics for a second. This is a big one. A lot of people think they're magic bullets, but here's what the evidence says. They should not be the only thing you do, especially not right at the beginning. They can definitely be a helpful piece of a bigger puzzle that includes things like stretching and manual therapy, but they are not a standalone fix. You know, just as important as knowing what to do is knowing what not to do. And the evidence is surprisingly clear about some really common treatments that, well, they just don't make the cut. I'm sure many of you have heard of this one, or maybe you've even had it done at a clinic. Therapeutic ultrasound. It's one of the most common things you'll see in physical therapy, but for plantar fasciitis, does it actually do anything? And here is the definitive answer, coming straight from that grade 8 evidence, the highest level there is. The answer is no. The guidelines are super specific. Clinicians should not use ultrasound with the idea that it's going to make stretching work better. The research is clear, it just doesn't add any benefit. So beyond the clear yes and the clear no, we've got this maybe list. These are treatments with moderate evidence, which means they can be really helpful for some people. This bucket includes things like strengthening exercises, dry needling, which uses tiny needles to release tight muscle spots, and low-level laser therapy for short-term pain. They're all valid tools, but they're not considered the universal first-line treatments like stretching and manual therapy are. Okay, so how do we take all this clinical info and actually put it together into a plan you can use? Let's translate all this evidence into a clear, actionable strategy for you. All right, here's your game plan, step by step. Step 1, start with the active treatments. That means prioritizing stretching and targeted strengthening. Step 2, add in the support. Talk to your provider about those grade A options like manual therapy or taping. Step 3, think about the nuanced options. Ask if maybe orthotics or dry needling are a good fit for you. And finally, step 4, be an empowered patient. It's okay to question treatments that aren't backed by the strongest evidence, like ultrasound. And this is so important. Even the people who wrote these guidelines emphasize that you are a key part of the equation. These recommendations are the starting point, but the final plan has to take into account your specific situation, what you want to achieve, and your preferences. It's a partnership, plain and simple. So, we'll end with this one question. The science is always changing, and the most important thing you can take away from all this is having the confidence to ask, is my care truly built on the best, most current evidence that's out there?